All right, let's go ahead and get our slides posted and let's get started. So today we have our webinar is going to be addressing a very important topic of how to manage mosaic embryos within the clinics. We have a great set of panelists, which I'll introduce now, and then we'll dive right into the important topic so that way we can give as much time to our discussion section. First, we have Dr. Till Taylor, who is the laboratory director at Reach, North Carolina, which is part of the Care Fertility, being the largest IVF center in the Carolinas. He's credited in conjunction with Roper Genetics as biopsying the first blastocyst, which resulted in a live birth using NGS screening. His passion is fly fishing and traveling. Next, we have Dr. Vicaria, the IVF laboratory director in San Jose, California, a division of Sutter Health. After completion of her MD and PhD degrees, Dr. Vicaria continued her postdoctoral training at the Scott Department of Urology at Baylor College of Medicine under Dr. Dolores Lamb's instruction. She then moved to San Francisco Bay Area to direct the reproductive laboratories at the Fertility Physicians of North California, presently Reproductive Endocrinology and Fertility Department of Sutter Health. Over the course of her career, Marina participated in multiple clinical trials and scientific projects and authored multiple research papers and book chapters. Marina remains active in the field of reproductive biology. She's current president-elect of the Society of Reproductive Biology and Technology, also a voting member of board of directors at American Board of Bioanalysis. In the past, she served as the president of NCARB and CRB. She also served on various committees at ASRM and CRB. As service to her professional community, I love this one. Marina runs a free online study group for hundreds of colleagues who seek to challenge the ABB board certification in embryology and andrology. I applaud you for doing that. Thank you for that service. Next, we have Dr. Eamon Bayless, who earned his PhD at Utah State University in animal science, specializing in reproductive biology, where he studied bovine oocyte activation. Upon completion of his degree, he joined the Utah Fertility Center as an embryologist. He loves the challenges of an IVF lab, as well as a great laboratory team at Utah and Idaho Fertility Center. So thank you so much for joining us, everyone. Let's go ahead and get started. I will go ahead and turn it over to Dr. Taylor to discuss some of those important topics for us.
Thank you, Sheila. So at Reach, we pretty much we're not transferring mosaics until probably about 2 years ago, when the first report, 2 or 3 years ago, when the reports first started trickle in that live births were turning out completely healthy. And we knew that the genetic counseling situation amongst these reference labs was, I don't want to say tragic, but the lack of genetic counseling time was apparent, trying to get patients through the door to discuss, carrier screening or to discuss all these types of abnormalities with PGT. So we decided to use, you can go on to the next one, sorry. We decided to use a maternal fetal specialist as an alternative. And the maternal fetal medicine specialist is part of our group, not Reach in general, but part of the larger medical association within Charlotte. And what it does is it keeps the patient in the active system. So it's an active referral. So it makes our referring doctors happy. It actually gets the patient through the system much quicker, and as opposed to a phone consult with a genetic counselor. And it's the exact same scenario, though. The maternal fetal medicine specialist will go over, the best and the worst case scenarios for those mosaicisms. And we are only transferring low-level mosaics at this time. Next slide, please. Go back. There you go. Go forward. There you go. We've only done 4 mosaic transfers, so not a lot. Unfortunately, a lot of these patients And all 4 of these mosaics are negative, by the way. Unfortunately, when a lot of these patients have these maternal fetal medicine consults, a lot of them discard their embryos after the consult. So they don't even want to attempt to try once they figure out, what are the possible worst outcomes for transferring this particular, abnormality. So a vast majority do discard their embryos after their MFM consult. And we do about, 500 PGS cycles a year. So, we probably transfer 1 or 2 mosaics a year, not a lot. And that's all I got.
Excellent. Thank you for sharing that. And then next we have Dr. Vicaria.
Okay, so we do have my first slide up, right? Okay, good. So thank you so much, Sheila, for this wonderful opportunity, and thanks to Progenesis for their educational efforts in general. As you can tell from the introduction, I'm a big fan of educating our youngsters and the field in general. So thank you. I applaud you guys for this. I just want to very briefly introduce my program, and then pivot from that to the philosophy about medicine in general that we practice, and PGT in particular. So our practice has been in this current form in business since 1988, which makes us one of the oldest programs in the Bay Area. And I have been with the same group since 1997. But just a side note, I married into this amazing family very young, so don't get any ideas about the old age here, just saying. So,
Dr. Marina, we've lost your video.
Oh, I'm so sorry. Thanks for saying that. Let me try to fix it. So sorry, I warned you this was an issue with my computer, and I apologize.
No worries.
There are 5 REIs in our program, and I have 5 senior fully trained embryologists, plus 1 embryologist gosh, it's doing it again. Gosh, I'm so sorry. We'll probably have to kind of accept this as a sad fact of life. I have 5 embryologists, seniors, who are fully trained, and I have 1 more who is in training right now. And we also have 2 laboratory assistants to support 5 last year, at least 500 egg retrievals and 700 frozen embryo transfers. As far as PGT, just a fun fact, we were the first IVF program in the Bay Area to report 2 live births from the same stimulation cycle, 1 fresh and 1 frozen, for what we now call PGTM, single gene at the time, for the non-disclosure Huntington's disease. And this was in 1998 or 99. We have a lot of experience technically with technology, with all kinds of biopsies and fixation techniques, you name it, we've done it over the years. As for PGTA in particular, as you can see from this slide, our PGT volume is lower than the national average. For example, in 1990, in 2019, the national average was about 43% of PGT usage, and ours was only 19%. But over the years, due to the Okay, video is back again. So over the years, due to the popular demand, this volume has increased, as you can see. So we are now up to 42% last year, but I bet you it's still lower than the national average. I bring these numbers mainly to illustrate that we are somewhat of a conservative philosophy in general and don't tend to jump on popular trends until they become well-established standards of practice of medicine and are backed by very strong data and evidence. And to summarize it, we jumped, like for instance, we jumped on a single gene testing wagon right away. We never really jumped on the fish wagon and are thankful for that and missed all the fun of that followed. And we are still exercising somewhat cautious approach with the PGTA still till this day. So hence 40 something percent last year of the usage. So as far as our SOP, we biopsy on day 5, day 6, and rarely on day 7. We keep all embryos in storage until patient directs us to no longer do so. And we don't discard any embryos abnormal or mosaic without patient's written and notarized consent. We only transfer embryos that are officially diagnosed as euploid, and this is clearly outlined in our consent form, so patients know from the beginning. And of course, they're told that there may be some other programs that may consider transferring mosaic embryos, and we will assist them in locating and referral to such program and the transportation of their embryos. And I'm sure you all saw the recent report about even abnormal embryos being transferred. So patients need to know this. We don't necessarily, advocate for this approach, but patients need to have all this information. So we don't officially transfer mosaics, but this is where it becomes complicated and a little tricky, because as you know, I forgot to mention that currently we exclusively use Cooper Genomics for our PGT needs. And as we all know now, they report low-level mosaics and high-level mosaics, but the programs can still, or physicians rather, they can still opt out of that reporting and have it basically masked and still report euploid versus abnormal. And our physicians, even though they generally, practice as a group and have, pretty standard approach for their stimulations and, consultations and things like that, for this, they do have a little bit of a variation, and some physicians order mosaic reporting and some don't. And as a result of this, that some don't, we of course are transferring some low-level mosaic embryos without knowing this, but we do. So that's basically our practice regarding mosaic embryos. As far as our SOPs, I was asked to talk a little bit what they're based on. And in general, at our practice, we try to, again, have a very defensive approach to our practice of medicine. And we always try to base our SOPs on the most current ASRM documents, if such documents are available. And so our current SOP is still based on the ASRM guidelines from 2020. And I think in the light of the new data about mosaic embryos, it's reasonable to expect the new SRM guidelines sometime soon, although I don't have any inside knowledge that they are being worked on. And this particular guideline, somewhat outdated, 2020, it basically says prioritize euploids for transfer. Well, of course, and as far as mosaics, they basically state the obvious. It's complicated, we don't know much, and basically inform the patient of the risks and swim at your own risks, at your own risks. So we have been internally as a group discussing this new data that is available, and we are open to maybe considering low-level mosaics if all euploid embryos have been used up. So this new ESHRE guidelines are helpful in that regard. And if I can have my second slide. Okay, so I tried to put some of our data together, and this is a little bit of a tongue-in-cheek slide, and I'll explain why. So this is all our PGT cycles over last 4 years. So a total of 438 PGT transfers, positive beta about 72%, clinical pregnancy about 63%, and implantation rate also 63%. We do follow SRM guidelines for the number of transfers, number of embryos transferred. So it's one embryo if they are tested, regardless of patient's age. And sometimes we still get twins, as you know, very rarely, but we do. So that's why this number is a little higher than this number, implantation versus clinical pregnancy. This next two columns are separated by the best I could. I separated them with reported mosaics versus not. So this first column does contain some mosaic embryos that were transferred without our or patient's knowledge. As you see, the numbers are identical, but this is where, the word of caution comes in to how to interpret statistics. And this slide technically doesn't tell us what I wanted to tell us, because our general mosaicism rate is, for some reason, which I don't know still why, it's much lower than the national average for Cooper Genomics. So ours is 8% versus about 16 or 17% nationally. And if we assume that of this 8%, 4% are low-level mosaics, and then of those, how many did end up in this pool, we don't know. So it's probably a very, very low number of mosaic embryos in this first group. So we can't really say if it affected anything or it didn't. The numbers are just not there. So basically, that's all I had to say on the subject, and I thank you for your attention.
I think you're muted, Sheila.
Thank you so much, Dr. Marina. Thank you. Next, we have Dr. Bayless. So go ahead and take the floor.
Awesome. I am honored to be part of the Progenesis Academy, so thank you for allowing me to be part of it. I have no commercial or financial interest in anything at all. I also just made a note there that we are part of the Ivy Network of Fertility Practices. We joined the end of last year, so it's been a great network to be part of. So on to the next slide, where we'll go through a little bit about the practice here in Utah. So Utah Fertility Center is made up of 5 physicians. And we also have a center in Idaho Falls that we're partners with, sister company, as well as several satellite offices and labs throughout Utah. We have a younger patient population, I think, than most other centers across the nation. Our average patient age is around 33 years old. We are currently freezing about 7 embryos per egg retrieval. We have a total of 11 embryologists right now. We're doing about 85% of all of our fresh egg retrievals are PGTA cycles, PGTM cycles, and about 10% are freeze-alls, and about another 5 are fresh embryo transfers. So we are biopsying the majority of the embryos that come through the lab. We don't discard any embryos regardless of their chromosomal state. So all embryos are kept following the return of the results. So we do have, aneuploid and mosaic embryos in storage. And so we do have a policy, much like Dr. Taylor, the last couple of years, we began to transfer mosaic embryos. So here, these bullet points are just a list of some of the requirements that are part of our SOP for transferring mosaic embryos. The patients can't have any euploid embryos available. So it's their only opportunity for a biological child. And I think we all understand the constraints of, finances. They could always go through another cycle, and maybe there's issues surrounding that. So it's definitely up to the physician and the patient when that bullet point's being addressed. The second requirement, or reason for a mosaic embryo transfer, is either a religious or a psychosocial belief that directs that decision. We do require the patients have met with a genetic counselor. Typically, it's through the testing company. We prefer to send all of our biopsied samples to Progenesis. So we will use their genetic counselors as a resource. And we also offer, we don't require it, but it is offered and suggested that they meet with a mental health professional to discuss the implications surrounding that decision. And then, of course, they have to complete all appropriate consents. We have an additional consent besides our frozen embryo transfer consent that outlines the risks and liabilities and all those things associated with transferring an embryo that has been tested and reported as mosaic and abnormal, or abnormal, I should say. We transfer both low and high level mosaics, or we have. And so if you could move on to the next slide, we can kind of go through some of those numbers. Not a large number, but in the last couple of years, we've transferred a total of 16 mosaic embryos. I tried to be a little descriptive in what information we do have. So of those 16s, we've transferred 3 that are high level mosaic, 8 that are low level, and 5 that are unknown. Those unknown mosaic, some of them have come from outside labs and another testing lab that didn't report whether they were high or low. They had a cutoff that, if I remember right, it was 25% was the threshold. So anything below that, I think, was classified as euploid. I might have wrote that wrong there with the greater than 25%. I think it was between 25 and 50% was mosaic, and above that was aneuploid, and below that was euploid, if I remember right. Of those 16 mosaic embryo transfers, we did have a total of 6 that had a positive pregnancy. And then to kind of trickle down, 2 of those 6 were only biochemical, and both of those that were transferred were high level mosaic embryos. Of those 6 positive pregnancies, obviously there were 4 of those that were clinical intrauterine gestations with a fetal heartbeat. One of them was a spontaneous loss. That embryo was specifically mosaic at chromosome 21. So far, we've had 1 live birth, and that was from a high-level mosaic embryo. And we currently have 2 ongoing pregnancies, one due approximately in April and one due in June, and both of those were low level. And then the last few columns and rows there just go through our transfers of embryos from 2022 that were PGTA tested. we transferred a total of 981 FETs. We did that number of FETs that were PGTA tested. We had 78% came back with a positive HCG, 68% were clinical intrauterine gestation, and I don't have all the live birth outcomes, but we're seeing about a 13% miscarriage. So that overall live birth rate is going to be like in the low 50s, I would guess. So that is what we have done here in Utah and kind of where we stand with Mosaic embryos. And I think that's my last slide.
Thank you so much, everyone, for sharing your specific protocols and some of your data, because many of our lab members don't necessarily have that live birth data to share. And so this is such an important topic because, as you know, as you can see with our speakers, we have a variability in practice where some centers perform high rate of embryo biopsies, whereas other centers are more discreet and identify certain patient groups that the PGT will benefit versus other patient groups that may not benefit from this test. And so each respective site has their own SOPs. So we struggle with today, as we notice that we're getting better and better in terms of resolution when it comes to PGTA. We are noticing that there is a potential risk that we're on in the form of mosaics or embryo transfer policy, deletion, duplications. And so how to navigate through those SOPs to make sure that your specific sites are protected when it comes to liability in the event there is an right, with incorporating the guidance that is available to us is also important. What we've done is we shared a poll with our audience, and I'd like to either invite Dr. Arash or Maddie Glorioso, who is our Associate Director of Clinical Operations with a background in genetic counseling, to share the poll results with us. So I'll go ahead and turn it over to them now. Okay, perfect. So number one, Maddie, would you like to go ahead and go through that? You're muted.
Absolutely, yeah. So the first question was, of course, do you transfer mosaic embryos? And we have about 61% of our attendees saying yes, they do transfer low-level mosaics. About 7% of attendees saying yes, they transfer all mosaics. About 15% saying no, they do not transfer any mosaics. And then about 20% saying they do not know. So it seems that the consensus, the majority of individuals are indeed transferring mosaics, but at the low level.
All right, and then we'll address these questions one by one, but go ahead and go through all of the answers, please. Perfect.
And so that second question was whether or not genetic counseling is required prior to transfer of a mosaic embryo. And so 69% of individuals were saying yes, they do require genetic counseling. 13% do not, and about 17% are not sure. And then our last and final question was whether or not NIPT, CVS, or amnio are required after a transfer of a mosaic embryo. And so 60% of participants indicated yes, it is required. About 8% indicated that it is not. And about 32% of individuals stated that they are not quite sure.
Excellent.
So thank you so much to
sharing.
everyone for participating in that poll.
Perfect. And then we can go ahead and stop sharing the slides, please. So let's go ahead and just have an open discussion. As you saw with the poll answers, we can see that a majority of our audience and our members are aware of the risks that are associated with the transfer of mosaic embryos. And what I believe as lab staff want to do, and clinical staff, is that provide the best chance possible to our patients and make sure that we're not taking away from any chance of pregnancy. So given that, if I can, as far as the requirement of genetic counseling prior to mosaic embryo transfers, can I have from our speakers some comments on whether your respective centers, I know not all of them, not each one of you allows for mosaic transfers, but in the event that you should consider it,
Sure.
do you currently recommend that? And is that something that the patients know of ahead of schedule?
I'll go first. We do recommend it, but we really don't talk to the patient until they have the results. They typically don't even get any type of discussion about what mosaicism is until we actually diagnose it. But I do, all the current literature out there, and more importantly, the Capalbo study of 2021 shows that there really is a minimal risk, if not none, for these low-level mosaics. And I'm willing to bet if you go on the high side, there's probably not much risk either. So why are we so gun shy in terms of why are we so afraid of our own shadow with this? We have obviously been transferring abnormals, mosaics before NGS testing, and babies were fine. So, I don't understand what, I get it, right? You have this information, you have to act on it. But at the same time, are we being a little overly cautious having, all this recommended genetic counseling, all this to, jump through these hoops when a majority of patients are going to throw away a perfectly, healthy embryo? And then on top of that, everyone diagnosed mosaicism completely differently. Some mosaics are only only one chromosome. Other PGT labs will say, well, if I'm mosaic on two chromosomes, I'm going to be abnormal. So there's just so much misinformation out there, and I think the patients are suffering. And I'm not sure there is much risk in transferring low-level mosaics.
What do you believe, Dr. Marina or Dr. Aman, regarding the liability associated with it? Because I think the key factor here is that when you transfer an embryo and do not perform PGT, or you don't have those results, versus if you don't have the option of knowing whether a mosaicism, the presence of a mosaicism is prevalent in your embryo, you are somewhat protected when it comes to the liability aspect of it. And so, like you said, Dr. Taylor, now that you have to act on it. So what do you do? Protect yourself, but all the best do for your patients. So how do you do that?
I'll be happy to go next if that's okay.
Marina, with you.
Yeah,
Absolutely.
I agree with mostly everything that Dr. Taylor said. It's when we don't order a test, then we follow one set of SOPs, and that's well known and presented to the patient as such. If we elect to do the testing and then get results, we need to act upon these results. And if we don't know how to act upon these results, then why did we order a test in the first place? That's against pretty much everything that is taught in medical school on the subject. So it's still, I think, we don't know, basically. I keep disappearing on you. I apologize. So, we don't know all the answers, and there are risks, even if they are small and they are theoretical, there may be risks. And based on the results, we do see that this embryos do result in more miscarriages, the mosaic embryos. And in my experience, and I'm sure we all agree that for some patients, miscarriage is a bad outcome. It's just as bad as not being pregnant or, having lost their baby, maybe more than not being pregnant. So that's something to be considered. They don't. Many people do PGT because they don't want to have a miscarriage, and then all of a sudden, we are offering them embryos that are at higher risk. So I think the jury is out. There's just so much we don't know. And we don't know, and oftentimes we don't know if a particular patient will benefit from PGT in general, or we are doing, them disservice by even doing the biopsy and all that. So the answer
I
is we don't
agree.
know.
We are walking a fine line and offering as much information as we can to the patient, but certainly with caution. Dr. Bayless, do you have anything to add to that?
I think you both have, I agree with you both. That's why I like going last, because it's just like, oh, I agree. Good job. It's just so challenging from my opinion and perspective, because every patient has a different backstory. And we really try to rely heavily on patient autonomy and allow them to have a lot of choices in directing their care, maybe to our fault sometime. But if it's their only option, then I agree with Dr. Taylor. I think the risk is fairly low. I also agree on the other side that, their miscarriages are higher. So it's such a sensitive topic that I hesitate to ever be too opinionated one side or the other, because I see both sides.
Mhm.
I do have a question from our audience regarding thoughts about B mosaic versus A mosaics. Any insight would be appreciated, or if our speakers could let us know if they need more clarification in order to discuss that topic.
I
don't
wonder
know
if
what
that's
A
referring
mosaic-
to, yeah, high level versus
Right.
low level, probably.
that's
So
what
let's try to
I
have our
was wondering.
discussion there. And April, if you will clarify if we have it wrong, please. So we did address high level versus low level, but given that our technology cannot accurately detect down to a percentage, right, for NGS, any NGS technology cannot do that. So it was in the ESHRE recommendations actually to instead use non-categorical definitions such as putative or suggestive of mosaic, and
Mhm.
instead of like a exact percentage. So what are your, I mean, I know that we share data with transfer of high level mosaic versus low level mosaic versus euploid, but as far as the overall risks based on your experience, to answer this audience member's questions, what are your, she's asking, what are your thoughts? I mean, what are your overall impressions? Dr. Bayless.
I
You
don't get to
can
go
go
last.
first now.
Okay,
Now that
that's
we
fair.
know.
That's it's fair. We all have to take a turn. I think my preference, and again, not as a lab member, I don't interact or counsel the patient, so I try to stay in my lane. But my personal kind of opinion would be, I would prefer to transfer a low level over a high level, something in the high range. So that's kind of where I sit. I just think the risk is lower, the mosaic level is lower. So I think it kind of goes hand in hand.
So I have to ask you, you shared data that stated that a high-level mosaic embryo transfer resulted in a live birth. Can you comment on whether or not there were any abnormalities at birth of the child or of the fetus or infant that was born? Do you know? Do you have that data?
None that were noted.
Okay.
So
Okay.
nothing was reported back to us. So, but our communication with the patient upon a live birth is, I think,
Minimal.
fairly generic. It's like, oh, how did the pregnancy turn out? What day was it born? Do you have a gender? How much did it weigh? Were there any, kind of to complete the SART requirement?
Generalized.
So like, it may have had blue eyes, one blue eye and one green eye. I don't know. But to my
Fair.
understanding, there was nothing egregious. It was a high level mosaic, and you guys that are more of an expert can help me with this. But on the slide, I did make a note of what it was. It was, I think, something to do with the X chromosome as a del, and then in parentheses X PTER P22.2. So maybe
Dr. Arash, maybe you
exactly what
can
that is.
expand on that. I mean, those sex chromosomes are difficult ones, right? Because they could result in live birth
Absolutely.
outcomes like viable aneuploidy. So you certainly assume some level of a risk when the outcome is unknown, right? You don't know. On hindsight's always 2020, I believe here. But yeah, there is certainly the gender chromosome abnormalities are definitely harder. How about you, Dr. Taylor? You reported 4 mosaic embryo transfers with.
I don't want to say blasé, but I would be much more open to it to transfer of high mosaics. Unfortunately, it's not my practice. So my doctors are the one that dictate that. And that's fine. I'll that's fine. That's their business. My only concern is we also treat every single chromosome equally with a high mosaic, So what if a monosomy 3 high mosaic, that shouldn't be treated as the same thing as like a high mosaic for, chromosome 21. So there's just a lot of apples and oranges, and we still don't know, what is clinically significant, what's not. And that I think is where, the GCs come in. And so I think there's going to be variability amongst chromosomes, not just high mosaic or low mosaics.
I think that's a great point, and that kind of segues into another question from our participants, specifically regarding the risks in transferring a low mosaic trisomy 14 embryo. So if any of the speakers have insight on that, that would be great. If not, there are some pointers from the PGDIS guidelines that I'd be happy to comment on, but I would love to turn this over to the speakers first.
I'll be happy to chime in just in my general thoughts. I just think that it's obvious that we're not anywhere close to having some data that can be analyzed and like reliable conclusions made on basically which mosaics are what, and what are the risks of, let's say, chromosome 11 versus chromosome 12. I mean, it's going to be a while until we have enough transfers, and then all the combinations come in, and with like 46 chromosomes and all the possible combinations. I don't know if, and I'll defer to the geneticist who knows the statistics much better than probably we do, but I don't know if we will ever have the data on all the possible combinations. I mean, how many thousands and hundreds of thousands of mosaic transfers does it take to come up with the answer to that, like, particular, questions about like a particular chromosome? I really don't know.
Yeah, definitely lots to consider in those possible combinations. One thing I can comment on is with chromosome 14 specifically, that is one of those chromosomes that is involved in uniparental disomy. So if trisomy rescue were to occur, we do start to think about things like Temple syndrome or Kagami-Ogata syndrome, which do have known phenotypic associations. So sometimes, oftentimes these are based off of theoretical possibilities, but based off of these guidelines, that is one of the lower priority mosaic embryos to transfer. So we do have some thoughts surrounding those possible outcomes. But yeah, thank you, Dr. Marina.
Yeah, of course. And can I say something just from our own experience about the involving the maternal fetal medicine and the process? I really, like what Dr. Taylor's approach is. And I have to say that we tried that. We have a fairly, extensive and famous maternal fetal medicine department at Sutter Health. But in our experience, they don't want anything to do with this sort of counseling, neither their physicians or their genetic counselors. And yes, they are busy, that's one side of the story. But the other side of the story is that they really are at loss about how to consult these patients at the time.
Yeah, I certainly think we're probably not the norm. But at the same time, my concern is genetics becomes more involved with the IVF space. Those GCs, they're already strapped for time, and it's not getting any easier for them.
No.
And so, we took the avenue of least resistance, and it's turned out well for us.
We'll take a couple more questions from the audience, and I'd like to focus our attention then of this panel on the actual SOPs that go into the the allowing of mosaic transfers at a clinic. So let's go ahead and address Vivian Stein's question. This is one that I believe many people will benefit from. So her question is day 7 mosaic embryo worse than day 5? Anyone who wants to answer the question is welcome. She doesn't have a preference.
Is she saying a day 5 mosaic or a day 5?
Day 7 versus day 5 mosaic.
I mean,
Both
okay.
mosaic.
I mean, just for the fact that it's day 7, it would be my last choice.
Sure.
Agreed.
So I mean that's what I would go by first. Transfer the day
Same.
5.
And I believe we have data that also suggests that day 7 embryo, as far as implantation and live birth outcome, is the lowest
True.
compared to day 5 and 6. Absolutely. And then, of course, there are other factors you can outline, but I think the question was more specific to mosaic. So I guess if you have both day 5 and day 7 that are mosaic, you would choose the day 5 primarily. And then, of course, layer on more information as far as additional variables to make informed decisions, depending on which chromosomes are mosaic versus, patient age, risks of abnormal outcomes, etc. The next question is Kelly Jean. What are the risks of transferring an XO mosaic embryo?
I can address that maybe. So XO mosaic embryos are compatible with life. So in the course of 7 years of providing PGTA testing, we had one pregnancy that was mosaic for XO that had 40% XO karyotype. These, but unknown percentage at the biopsy level, and it was not detected in NIPT either. And so, XO is compatible with life. Just like a trisomy 21, there is about 5% of the kids with Down syndrome are mosaics. And that goes also for chromosome 13 and 18. Anything that is compatible with life, mosaicism form would also be compatible with life.
There is a working theory that states that most individuals with Turner syndrome, which XO is, actually do consist of some kind of mosaicism. So certainly, yes, the XO would be associated with Turner syndrome compatible with life.
So that answers one of our audience members' questions, Erica Ewert, who was asking that, like, do you, when you decide to transfer mosaic embryos, do you only allow for low level versus high level? So what I'll do is I'll take that question and divert over into SOPs now. So when we're determining at the clinic level or at the laboratory level, one, are we going to allow procedures involving mosaic embryos for transfers for our patients? So one, we come to a decision based off of the resources that we have. And then two, what SOPs, what goes into developing an SOP, so that way not only is a patient well-informed and educated prior to making this decision to proceed forward with a mosaic embryo or a segmental loss or duplication transfer, and then also at the same time, making sure that we protect the medical operation and the laboratory operation from an increased liability, because now we know a piece of information that might result in an unfavorable outcome. So to protect, all of our employees, our organization, to make sure that our doors remain open so we can serve additional patients in a continued fashion. So if I can, I know that we could just go like in order of presentation. So Dr. Taylor, I'll have you go first, and then I'll have Dr. Marina, and then Dr. Bayless, you'll go last, please.
Can I not go first? I was reading the questions in the.
Sure. So next in line, Dr. Marina.
I'll be happy to go first.
Sorry, my ADD kicked in.
Yeah, I will be happy to go first, especially since I'm known behind my back as an SOP nerd around here at work. So yeah, stop me if I talk too much. So basically, the first, we're, like I said, we are considering, offering Mosaic transfers to our patients if nothing else is available. So of course, we're thinking SOPs. So the first step, of course, is that patients need to know about the possible outcomes. So when we offer them PGT in general, they need to know ahead of time what the results might be. So we may have embryos that are clearly euploid, the embryos that are clearly abnormal, and then something in between, which is mosaic. So our patients do know that even now, even though we don't transfer those, but they do know, especially if it's ordered. But even if that's not ordered, it's actually physicians who don't order it, they disclose it to the patient. They say, this is an option. I generally don't go with this option, and this is why. But if you want me to go to have it disclosed, then fine. We also had some patients who didn't have a mosaic disclosure at first, but then after not getting pregnant and the first transfer, they actually asked a new set of PGT results with the mosaic disclosure. So that will be the first step of the SOP, to have a good patient consult and the consent about what to expect and what will be transferred and what's not.
So
And
may I ask, regarding the
yes.
consents, do you offer that information in the IVF consents, at the time of stimulation prior to
Correct.
retrieval, versus only introduce this at the FET consent?
No, it's in the IV. This needs to be just by definition, actually, of informed consent. This needs to be ordered at the. This needs to be disclosed and discussed at the time when procedure is ordered. The test is ordered. So we're ordering the test with the stimulation, right? So before you order a test, you have to explain to the patient what the test is and why you're ordering it, and not after the fact. So. Okay, so now it's unable
So
to be.
Yep. So you
Okay.
discussed a very important point, informed
Yes.
consent. So that's step one. You have to make sure that it is in writing and the patients are aware of the risks from the beginning,
Absolutely.
prior to creating embryos and prior to
Absolutely.
doing the
Yes.
testing.
Yes, absolutely. And they need to know, the risks, and they need to know that they may end up with no embryos available for transfer as a result of this testing. So it's a very important part. And our IVF consent, actually, it's a combined consent. We don't have a separate consent. We used to, but now it's combined. There has a section on PGT testing, and if patients opt out, they opt out. But if they requested being done, then it has all this addressed. That's what we discussed. And then it comes to the lab in terms of how to manage these embryos. Like I said, we keep everything until patient tells us otherwise. And then we actually spend a fair amount of time in determining once the PGT results come in, determining the order for future transfers. So as soon as the PGT results come in, we actually take embryo grades on one side and the PGT results on the other side, and then align all the euploid embryos in the order of future transfer, taking into consideration the gender, like whether patients want certain gender or not, or they don't care. So that's a process. And if we were to go the mosaic embryo route, then I will have an SOP about after the genetic counseling results come in, on which embryos are, less risky, so to speak, for transfer. And then the embryos will be all, aligned on the paper in that order. So that's.
Dr. Bayless, let's go ahead and have you chime in regarding, okay, so we've established that we need an informed consent at the beginning of treatment, but once the patient cycles through, and let's say the patient presents with mosaic embryos as part of, as sometimes we have these patients that only have a mosaic embryo, one mosaic embryo. Well, then now you're faced with a situation where, okay, well, how do we proceed forward? And so what would you say would be your next steps as far as making sure the patient's well informed about the risks that are actually going into the transfer using that particular embryo with those particular results, and then also protecting the clinic on the backside?
Yeah, and that's kind of this, in my opinion, kind of some of the scary part. That 100%, it needs to be that expectation from the beginning from the physician that this is a possibility. And then in that situation where it comes back and that is the only option they have to have a biological child, that's one of our kind of check marks. And so then our next requirement is that they meet with a genetic counselor, because I know I'm not a genetic counselor and I don't understand all the risks associated with different mosaicisms. And so following that genetic counselor session, we get the report back, and then the patient again meets with either the physician or their nurse and discuss and make a plan from there. There have been some that following that genetic counseling appointment have decided not to transfer the mosaic embryos, but I would say the majority continue on. We don't have a lot. We've had 16 in the last 2 years. And I do know of a couple that have decided not to and have elected to discard all their embryos following the genetic counseling appointment. So I think that's so important that they have that expert genetic counselor involvement, because even the physicians, although they're excellent at what they do, they're also not genetic counselors, most of them. The ones here are not.
And that's exactly the point, right? So we
Yeah.
we have our specialties and we have our strong suits. So we protect the patient, give the patient enough information, and the same time we're obtaining that information.
Yeah.
So in light of that, let's say we go through a genetic counseling session and the genetic counseling reports that there is a risk of an unfavorable outcome. Well, then does the clinic reserve the right to decline a transfer, Dr. Taylor?
Yeah, I mean, we've declined transfers. Our doctors have declined some transfers. So it's up to both the patient and the doctor have to agree. And it's just like anything else. Sometimes patients want other treatment that we don't offer, and we will say, go elsewhere. We don't discard the embryo. We just say we won't do it. We know some other clinics that will. Here they are. Please feel free to go talk to them. So we don't discard the embryo. It's just something that the doctor has to agree upon as well. So it's yeah, that's important for sure, because they carry the risk.
So then do we include that? So is that something that is included in the informed consent on the front end?
You broke up. Can you say that again?
Yeah, I apologize. So is that something that is included in the informed consent, that the clinic reserves the right to decline an embryo transfer based on the genetic counseling report?
No, I think it's more implied. The doctor doesn't have to treat you. As a physician, you do not have to treat that patient. And we've kicked patients out of the practice for much other violations as well. So, or not violations, but other things that we didn't approve of. But it's a pleasant conversation. It's not attacking. It's just simply saying, look, I understand what you're saying. I just won't partake in this, but I am happy to facilitate it elsewhere. So we haven't had any pushback from patients, because we have sent 3 or 4 patients out to different practices because we won't transfer them, and they have, it's been nothing but cordial.
Excellent. So let's address the last piece of this SOP, and then we'll turn it over to audience questions again. So now that, let's say we transferred an embryo, which was mosaic, and the patient is pregnant. So do you require at your centers, or do you recommend highly to the patient any kind of screening or diagnostic testing once pregnant, and whether that's invasive or not invasive? So the next, let's go ahead and Dr. Marina, please answer that.
Yeah, the very short answer to this, yes, we can't require it, obviously, because if patients don't want to do it, they're not going to do it, but we strongly recommend, even with other forms of PGT, even without Mosaic being involved in the mix, we still discuss this option and recommend that it's done. So
A quick question for the rest of the panel. So part of the recommendation of transferring or not transferring the mosaicism embryos, mosaic embryos, the rebiopsy is still an option. Is that part of your counseling tool or your recommendation to rebiopsy an embryo?
No. just because, you know, it's just going to make, you know, it doesn't change the fact that it's going to be best case, it's still Mosaic. I mean, no, it just makes it more complex.
same
In our opinion.
Same with Mosaic. I mean, it doesn't matter that you've done it twice. It's still Mosaic, even if it comes normal the second time. I mean, to me, that's the definition of the Mosaic, right? You know, that some parts of embryos may not be Mosaic, and you know, if one part ever was, then that's it. But yeah, we've done rebiopsies for other reasons, for no results. That's an interesting, you know, set of data, because usually, like, oftentimes they come back as no results again. So which tells you it has
Also,
to
yeah,
do with
also, yeah, I agree. And also here, I think we have as clinical team members a responsibility to our patients to really vet our PGT labs and PGT partner labs. So have you, and I'd like to even poll the audience, have you researched or asked the question to your PGT provider that what is your rate of mosaic embryos across your or rather mosaic calls across all of your clinics? And what is your rate of euploidy per age group, which is a very important question, because what we might find is that there are variation in interpretation of at that step, which can help us, because then we can find on the back end, if we partner with the right provider, that we are increasing our usable embryos because the interpretation is of a higher quality, because there is not noise or associated variants that are incorporated into the calls labeled as mosaic, you know. So I think that's really important. I'd like to encourage our audience members to do that. But Maddie, if I can turn it over to you, let's go ahead and have a few more audience questions, please.
Absolutely. I think one of the interesting questions that perhaps our panelists can comment on was whether or not we can be truly sure whether the diagnosis of a mosaic embryo is indeed a true phenomenon, instead of a result of lysing cells in the process of obtaining a sample of a couple of cells. So essentially, is it true phenomenon, or is it artifact? Is it a result of the biopsy technique?
I mean, if you look at the literature by, you know, Nathan and Dr. Scott's and all those groups, they'll say that mosaicism's, you know, an artifact and of the amplification procedure. And so all these, and certainly the evidence by Capalbo suggests that low-level mosaicism is an artifact. So as soon as we get a clear picture of that high whatever's going on high mosaics, you know, it's either an artifact or it's clinically irrelevant. So, you know, those are the two options. But right now we just don't know. But I mean, they've done some pretty compelling research and validations, even suggesting, you know, that even segmental aneuploidy may not even be as significant as we think it is. So I think there's a lot to go on there, but I do commend those authors for all their work they're doing in that space, for sure.
The next question we have is, with the new but limited data coming out right now on transferring low-level mosaics, do you foresee more transfers of these happening in the future? And if so, how soon do you think it will be to have meaningful data in this space?
Also, do you feel like, per the ASHRAE recommendations, that the terminology low level and high level will just eventually stop being the standard term, and the industry will likely start using putative or suggestive of mosaic terminology.
I got to answer that one again, Dr. Bayless. You look like you're tired. You look like you need to answer this.
I am. I'm enjoying it though. I'm learning a lot because I'm just realizing I'm not keeping up on all this research, and I just do what I'm told. So like I really
That's
think
what we all do. That's what we all do.
you know, from my perspective, I think I like the term low level and high level. You know, I don't understand the testing aspects of it, but I also don't, I have a hard time believing that it's biopsy technique that could result in it. So I don't know, I might be way off topic with what the question was, because you're right.
I think there is enough data. Look at the data both on comparing labs, for example. There is enough data suggesting that you cannot have a lab report 2% and another lab report 20%. That's just impossible in a random population, right? So that tells you that there is some inconsistency in data, an artifact.
Yeah.
Then if you look at the studies that have transferred mosaic embryos, you don't see birth with mosaics that we know of. There are very, very little. And then you look at mosaicism rates in miscarriages, and it's very low. It's probably around 3%. So when you look at all these things all combined, there is no other conclusion than thinking that there is a lot of artifact in those mosaic calls. There is definitely artifact. Whether there is a minority class that is true mosaic, that's a different question. And so an artifact can come with many sources. And since you mentioned, Aman, you mentioned, embryologists, we've seen mosaicism rates goes from 0.5 to 5%, comparing 145 embryologists. And so how could you explain 10x mosaicism rates between the lowest and the highest? And not that some of them are not doing good biopsy. They may be doing a good biopsy, but maybe generating very little material that the lab is not able to analyze correctly. And maybe they are culturing in different conditions and stuff like that. But and then you add to this the sequencing platform or devices that are used, and you can see differences just by looking at the platform being used. So, and that's why I think artifacts are probably the most plausible explanation of the differences we see in mosaicism rates.
I think my comment was within embryologists in our lab. I don't think we have a huge variation in mosaicism, and I don't know what it is across the nation. So I think you're right, and my knowledge is limited with what I can see here.
But also, I think we have to take into account that, the larger centers benefit from having an on-site lab director and having constant training and having those annual competencies, et cetera. Whereas the smaller centers, especially the ones that use per diem embryologists, do not have that level of control. So we see the variation in the industry, which states that there is certainly some form of contribution of having that level of structure in your organization versus not. And then the second piece is, we're so focused on embryology technique and skill, which certainly is a contributing factor here, but also remember, we're analyzing small amounts of DNA. So even things like, what media did you use? Did you rinse your culture media appropriately before placing your biopsy in the buffer tube, may be what contribute to the artifacts that we're seeing on the back end. And then of course, there's other forms of contamination. So those are all things that need to be addressed at the laboratory level, and certainly, at the PGT analysis level are looked at maybe on the back end, once we identify that a laboratory is consistently performing at a level of higher mosaic calls or higher no call rates, et cetera. So then, you know, we'll try to work with each team member separately, but food for thought. Did you want to answer maybe 2 more questions, and then we'll go ahead and conclude our presentation?
Absolutely. In thinking about SOP development and clinic policies, I think this one is interesting. What are the panelists' thoughts on transferring multiple mosaic embryos at once? And also if perhaps you have considered or transferred mosaics alongside euploid embryos?
I'll answer that one. Also, we strongly encourage single embryo transfer regardless. So that's what we would push for. We have transferred 2 mosaic embryos at a time, and it didn't result in a pregnancy. So that's the only one I know of where we've transferred 2. All the others have been single. So I think you run the risk of multiples, you know, so I wouldn't recommend it.
And I'll second that if I can.
Yeah, concur.
Yeah, I think the industry is heavily favoring single embryo transfer, especially in the after PGT. So yeah, many of the larger centers are in agreement. Let's have another, Maddie.
Yeah, you know, I am noticing that a lot of these questions that are coming in seem to be coming from individuals looking for advice or guidance and next steps regarding their transfers. And I'd just like to take a moment to discuss that any advice should be, of course, discussed with a genetic counselor. Highly recommend speaking with those individuals in order to consider your next steps. Progenesis does offer genetic counseling services, and it is available to individuals who are interested in that. And let's see, let me look back at some of the questions. I suppose maybe one good final food for thought is PGS testing necessary for higher quality embryos, better outcomes?
I wonder what higher quality means. Does that necessarily mean morphological grade? Probably.
Probably.
Yeah.
And I think we've all seen beautiful, what we would call an AA embryo not result in a pregnancy, and a CC embryo result in a pregnancy. I think I want to make a t-shirt. Maybe I shouldn't say this because it might be $1 million idea, but I want a t-shirt that says I was once a CC embryo, because I think we were all a CC embryo. We had to progress. That's my opinion.
Yeah, I think at the end of the day, you know, we still have no idea in terms of what makes a baby and what doesn't. Even, you know, chromosomes are a big part, sure, but there are so many genes, so many activations, so many single processes that have to occur on time that we can't possibly test for. And, you know, the more testing we're going to do, obviously, the better the pregnancy rates are going to be. But at that time, we're going to be limiting the number of embryos that are available for a live birth. So is PGS testing necessary? No, everyone here in this crowd is a result of an unbiopsied embryo. So do you need PGS? No, you don't need it. But does it help? Yeah, it helps because it's an additional selection tool.
Yeah, I want to throw a statistics that we have on embryos, about 160,000 embryos that we have on our portal. If you randomly pick an embryo, an AA embryo, and you ask what is the likelihood of that embryo being a euploid, it's 60%. If you take a CC embryo, there is twice more likelihood of that embryo being abnormal than normal. So you can see the difference by looking at an AA versus CC. It's definitely the grade correlate with euploidy in our data.
Absolutely.
Our data too.
Absolutely. Ours too.
There's definitely a consistency. Well, thank you so much to all of our speakers to come in and give us their time and share with us their experience, their knowledge, their guidance on such an important topic, which I know several of us struggle with. And I I encourage that our audience members continue to support us in these webinar series, so that way we can go ahead and have renowned speakers like the current speakers in our panel and share our knowledge with other members as well. And I'd like to conclude by having Maddie announce our next webinar, so that way we can let you know what we have in store for you next month.
Thank you, Sheila. So yes, next month, February 8th at 3 p.m. Wednesday, we will be hosting a webinar regarding the challenges in decision-making during PGTA. So those difficult conversations that surround this process. We hope you tune in, and we look forward to your attendance. And I just want to say thank you so much to all of our speakers today and to all of our attendees for joining such a wonderful discussion.
Thank you, everyone.
Thank you for
Thank
having
you.
me.
Have a good night.
Our pleasure. Thank you.
Sure.
Mhm.